Hello and welcome to today's session. Today we're going to look at a mechanical ventilator. We'll be interested in the parts of the ventilator, the alarms, modes, settings, and how we do monitor a patient on a vent. So let's start by defining what a mechanical ventilator is. Mechanical ventilator is a machine that helps people breathe when they are unable to do so on their own. Mechanical ventilation or a mechanical ventilator can also be referred to as a respiratory or a breathing machine. And we have several indications for this procedure. One is patients who have having apnea or ventilator failure or impending failure or severe hypoxemia and respiratory muscle fatigue that has brought up as a result of diseases like GPS, right? Or myasthenia gravis. All right. Number two, we have patients who are presenting with respiratory cycle of over 30 breaths per minute. Patients who are unable to maintain arterial oxygen saturation of over 90%. Patient presenting with acidic bodies with pHs of less than 7.25 acidic. Patient with partial pressure of carbon dioxide of over 50 millimeters of mercury. Remember, you have to rule out presence of chronic conditions. So therefore, mechanical ventilation aims to improve gaseous exchange and decreases the work of breathing for the patient until the cause of respiratory failure has been identified and has been corrected. We have different parts of a mechanical ventilator, starting with the connection between the patient and the vent itself. We could either have the we could either have the endotracheal tube or the tracheostomy. You could appreciate the endotracheal tube on my left and the tracheostomy tube on my right. So from there, the endotracheal tube normally goes through the patient's mouth and into the trachea to facilitate exchange of gases, while the nasogastric tube will be put into through the patient's nose and into the stomach to facilitate the nutritional component of the patient. The other parts, we have the setting interface for monitoring patient and also the mechanical ventilator itself, the humidifier which normally warms and moistens the air before it's taken to the patient. So if it's a tracheostomy, we need to do some tracheostomy care, all right? So the first intervention that we need to know is that the priority intervention is to check for the tightness of the ties. And this is normally done by one finger that is normally fitted under the ties. And this is normally to help prevent dislodgement and loss of air and loss of airway. Remember, a dislodged tracheostomy, that means we are going to lead to loss of airway, which is a medical emergency. So if it is a mature tracheostomy, that is a tracheostomy that has been in place for 7 days or more, we could insert a new tracheostomy tube using a curved hemostat. Also need to cover the stomach with sterile occlusive dressing. Then ventilate the patient with a bag valve mask over the nose and mouth. If it's a new tracheostomy tube, that is, it has been in place for less than 7 days, you cover it with an occlusive dressing. Remember, if you're using endotracheal tube, you have to do a number of intervention, like you use an oral moisturizer on the lips and oral mucosa every 2 to 4 hours. And this is majorly to reduce inflammation and improve oral health. You also need to assess and record depth every 4 hours to determine whether the tube has been displaced or not. You assess the patient's vital signs, respiratory status, and ABG, and provide emotional support to reduce anxiety, even if the patient is unresponsive. Remember, oral care is used to prevent a ventilator-acquired pneumonia. Patient with ventilator-acquired pneumonia will present with positive sputum culture, fever of 38 degrees, chest x-ray showing new infiltrates. Such patients, you need to elevate their head of the bed about 30 to 40 degrees. You reposition them side to side and you provide oral care using chlorhexidine and perform hand hygiene. So when giving breath to this patient of a mechanical ventilation, we have four phases of a mechanical ventilation breath, and it's normally abbreviated as TICE. Where the first one is a trigger phase and is also referred to as the initiation phase. And in this phase, it's characterized by initiation of inhalation that is triggered by either by the effort from the patient or by the set parameters of the mechanical ventilator. This is followed by the inspiratory phase, and this inspiratory phase is referred to the delivery of inspired breath, so inhalation of air into the patient. From there, we go to the cycling phase, and this cycling phase is referred to as the termination of inspiration. So here we have a brief moment when inhalation has ceased, but before exhalation has begun. Lastly, we have expiratory phase. Expiratory phase, this is the passive exhalation of air from the patient. Remember, during the breathing and the exhalation, the ratio between inspiration and exhalation is normally 1 to 2 or 1 to 1.5. So the different parts of the ventilator that you need to be aware of, we have the display screen which shows real-time monitoring data such as tidal volume, respiratory rate, and airway pressure. You also have the control panel which allows healthcare provider to set the parameters like ventilation modes, fraction of inspired oxygen, the tidal volume, respiratory rates, and the positive and expiratory pressure. Then we have the gas delivery system. As you know, the inspiratory circuit delivers oxygen and air to the patient and include filters to ensure gas purity. Exhalation valve will regulate and measure the amount of exhaled gas, while the humidifier will add moisture and heat to the gas to mimic the natural humidification of the respiratory tract to prevent drying of the airways. For the patient circuit, we have the tubing, which connects the vent to the patients. It could either be the endotracheal tube or a tracheostomy tube, as we have mentioned. Then you have the Y-piece connector. This Y-piece joins the inspiratory and the expiratory circuits at the patient's interface. Filters prevent contamination of the device and protects the patient from external pathogens. The pressure sensors, this one they measure air pressure to prevent barotrauma or detect obstruction. We also have volume sensors that monitor tidal volume and minute ventilation. Oxygen sensors ensure the patient receives the correct fraction of inspired oxygen. The alarms, they notify the healthcare providers issues like disconnection, high pressure, apnea, and low oxygen supply. The power source, like the electric power supply, this operates the vent either through a direct power source or a battery backup. Compressed gas source supplies oxygen and or the air via the hospital pipes or the gas cylinders. The ventilator modes, like the microprocessor or the software, this one governs the various ventilation modes. It could be volume controlled, pressure controlled, CMV, CPAP, ensures proper functionality. Safety measures, like the valve systems, this ensures that excessive pressures are not transmitted to the lungs. Fail-safe systems, these are maintain ventilation during power failure or gas supply interruption. So we could have other components like nebulizer port for aerosolized medication delivery, or carbon dioxide monitoring, which measures exhaled carbon dioxide to assess ventilation efficiency, and non-invasive interface for the use with masks instead of invasive intubation. So for the ventilator alarms, we have majorly two types of alarms. We have the low pressure and the high pressure alarm. Starting with the low pressure alarm. Low pressure is also referred to as low tidal volume alarm, and this could be due to a loss of connection, and generally it's caused by leaks that we refer to as leaks. So leak could be caused by a cuff leak that is not tight enough, or the endotracheal tube displacement or disconnection. Decreased pressure will lead to leaks. That's what we need to know. So leaks or disconnection are normally the common cause of low pressure alarm. So we could have the troubleshooting. So disconnection of the endotracheal tube from the ventilator. What are you supposed to do? You simply reconnect the endotracheal tube to the ventilator. Displacement of endotracheal tube above the vocal cords or extubation of the tracheostomy. You check the endotracheal tube placement and reposition if it's necessary. If extubation has occurred as for the tracheostomy or displacement has occurred, immediately ventilate the patient manually and you notify the patient, the healthcare provider. If there is leaking tidal volume from low cuff pressure, you listen for the whooshing sound around the endotracheal tube, indicating an air leak. If you hear one, you check cuff pressure. If you can't maintain pressure, you notify the healthcare provider who may need to insert a new endotracheal tube. If the ventilator has malfunctioned, you disconnect the patient from the ventilator and ventilate the patient manually if necessary. You could also obtain a new or another ventilator. If there is a leak in the ventilator circuit, make sure all the connections are intact. Check for the holes or leaks in the tubing and replace it if necessary. Check the humidification device and replace if it has cracked. Let's look at the high pressure alarm. High pressure alarm are also referred to as high peak pressure alarm. And majorly it's because of a blockage in the system. Remember, the most common cause of high pressure alarm is a client coughing. And another common, especially when waking up from sedation, is fighting the vent. But we have more serious one like pulmonary edema, where we have fluid in the lungs, or pneumothorax, where a patient is presenting with popped up lung, bronchospasms, and so a kick in the tubing, secretions, obstruction, liquid in the tube, and so many others. If there is increased air pressure or decreased lung compliance caused by worsening diseases, you have to auscultate the breath sounds for evidence of increasing lung consolidation, barotrauma, or wheezing, and notify the healthcare provider if indicated. If the patient is biting an oral endotracheal tube, what are you supposed to do? You insert a bite block if necessary, and you consider pain medication or sedation if appropriate. If there are secretions in the airway which are causing high alarm, you look for secretions in the airway, you suction the patient's airway or have the patient cough to remove secretions as necessary. If the condensate in the large bore there's a condensate in the large bore tubing, you check the tubing for condensate and drain the condensate from the tubing as necessary. If the intubation of the right mainstem bronchus, you auscultate for diminished or absent breath sounds in the left lung fields. Patient coughing, gagging, or attempting to talk, you check the ET tube position. If it has been displaced, you notify the healthcare provider who may need to reposition the ET tube. Chest wall resistance, if the patient's breathing becomes asynchronous with the ventilator may order, the practitioner may order a sedative or a neuromuscular blocking agent and sedative. Failure of high pressure relief valve, you reposition the patient to improve the chest expansion and also administer the prescribed analgesics. If necessary, Following a safe medication administration process, you replace faulty equipment. If it's bronchospasm, you assess the patient to try to determine the cause. You report your findings to the practitioner and treat the patient as ordered. So there's a common question where you are being asked, a client with emphysema receiving mechanical ventilation appears restless and agitated. What is the priority action when a high pressure alarm sounds? Yes, you're supposed to instruct the patient to allow the machine to breathe for the client. Nurse Thomas is responding to a high pressure alarm on the ventilator. So on the ventilator, he will be assessing for which condition? Yes, you'll auscultate for lungs for the pulmonary edema, pneumothorax. You'll assess for patient biting the endotracheal tube. You'll assess for excessive air secretions and if the ventilator tubing has kinked. Remember this. The third and fourth, that is tube displacement and disconnect. These are all common causes of leaks which are associated with low tidal, low pressure alarms. So we have different types of ventilator modes, and the primary control variables in mechanical ventilation is either the volume control or the pressure control. Remember, a ventilator mode is a set of parameters that determine how a mechanical ventilator is going to be supporting a patient's breathing. And these parameters could be include timing, volume, pressure, of which you have mentioned volume and pressure as the major primary control variable. So the choice of a particular mode depends on the patient's respiratory status, clinical objectives such as improving oxygenation or weaning from the ventilator. The most common modes we have AC and CMV, right? AC, assist control, and synchronized intermittent mandatory ventilation. So positive pressure ventilators are normally controlled by what? We have said the two primary controls are either pressure or the volume. Which type of mechanical ventilator involves the chest cycles or the ion lung? If you have an artificial lung, then breathing will be based on the principle of negative pressure. List the common modes of positive pressure ventilation from the most common to the least common. We have the CMV, we have the AC, the IMV, CMV, the CPAPs. Of course, we have said that AC and CMV are the most commonly used. The advantage of volume controlled modes over pressure is that volume control modes, they ensure minimal minute ventilation. But their disadvantage is that the pressure is variable, so barotrauma is possible, and the volume is limited by high pressure alarm. What of the advantage of pressure limited over volume? In pressure, there is less risk of barotrauma. The disadvantage is that this type of mode doesn't ensure minute ventilation and tidal volume is variable. What two things are variable in pressure control modes? Pressure control modes, the volume, which is dependent on the set pressure and the flow. What are the four types of triggers? We have time, patient, pressure, and flow. What control is used to adjust patient's inspiratory effort? Or this is just based on sensitivity, the principle of sensitivity. What are the two types of sensitivity controls? Flow and pressure. So the CMV, the controlled mechanical ventilation, is a mode where the ventilator delivers a set or number of breaths per minute, and each breath is fully controlled by the machine. The patient has little or no control over their respiratory efforts during CMV. This mode isn't a standard mode on modern ventilators. That's why we've talked of the AC and CMV as the most common. So generally, control mandatory ventilation stands for the control mandatory ventilation is a Ventilator mode used in sedated, apneic, or paralyzed patients. All breaths are triggered, limited, and cycled by the ventilator. The patient has no ability to initiate their own breath. So the indication of CMV is that they need to have total control of chest expansion and minute ventilation. You use the CMV. So the patient is totally ventilator dependent. Alarms are essential. You may be unable to assess weaning, and seizures sometimes may interrupt the delivery of a breath. Assist control is a mode where the ventilator delivers a preset tidal volume at a set rate. So the patient initiates a breath on their own. The ventilator will provide support to ensure that the preset tidal is delivered. It's used when the patient is unable to sustain sufficient breathing, spontaneous breathing, normally used in CPR. So AC actively controls breathing. If you compare the work of the lung and the machine, actually it's the machine that uh, ensures that the work is done. So machine 100%. Indications of AC is this a patient who needs full ventilatory support. They need to support a high minute ventilation with low oxygen consumption and the need for sedation after intubation. The advantage of AC mode is that it keeps the patient's work of breathing requirement low. Then we have the IMV or CMV. This is intermittent and continuous mandatory ventilation. The ventilator delivers mandatory breaths at a set rate. And in IMV, intermittent mandatory ventilation, the patient can also initiate additional breaths between the mandatory breaths. While CMV, that's continuous mandatory ventilation, the patient has little or no control over the timing of the additional breaths. IMV was the first widely used ventilator mode that allowed partial ventilatory support, and it facilitates weaning and increases respiratory muscle strength, but is not widely used today. So today we have the CIMV. So what are some of the complications of IMV? Intermittent mandatory ventilation. We have breath stacking, where there's a spontaneous effort immediately followed by a mechanical breath, which leads to increased PIP, barotrauma, and other cardiac compromises. CMV. CMV, the ventilator delivers a set of number of mandatory breaths per minute, similar to CMV. And the patient here can also take spontaneous breaths between the mandatory breaths. So this is how it is different from CMV. The ventilator synchronizes its support with the patient's own efforts and allows for a more natural breathing pattern. This one is normally used in the weaning process when the patient is transitioning to a more spontaneous breathing. Patient controls breathing mainly, but the machine assists. So we could have, like if you compare lung to machine, you could be having a percent like 60-40 control. So it's a step down from controlled. CMV stands for Synchronized Intermittent Mandatory Ventilation and is a ventilator mode that provides assisted support that is synchronized with the patient's breathing. The ventilator senses when the patient is taking a breath and then helps deliver the breath. Spontaneous breathing by the patient can occur between the assisted mechanical breaths, which occur at preset intervals. If the patient fails to take a spontaneous breath, the ventilator will provide a mechanical ventilator. So when is the CMV preferred? It is preferred when the patient has an intact respiratory drive. And how is CMV similar to CPAP and BPAP? They use breaths that are spontaneously triggered by the patient. So for the CMV, the CPAP, the BPAP, actually the patient is the trigger. Primary indication for CMV is that it's indicated for patients who need partial ventilatory support. What happens if the rate is set high in CMV? This will provide full ventilatory support because CMV with no spontaneous rate is essentially the same as assist control. What happens if the rate is set low in CMV? It facilitates weaning and strengthens the respiratory muscles and decreases the mean airway pressure, making spontaneous breaths have a lower peak pressure than the mandatory breaths. What are some complications of the CMV mode? We have a low rate can increase the patient's work of breathing, causing respiratory muscle fatigue. So we need to assess that. So what mode has a positive baseline pressure continuously applied to the circuit and airway during both expiration and inspiration? This one we have the CPAP. In which mode does the ventilator deliver a time triggered breath, allow the patient to breathe at their own tidal volume between mechanical ventilation? We have the CMV. In which mode does the ventilator deliver a set tidal volume of pressure at a time triggered rate, but the patient can trigger a mechanical ventilator above the preset? This one is the assist control. In which mode does the patient not trigger mechanical or spontaneous breath and there is no negative deflection of ventilator graphics? This one is the continuous mandatory ventilation, CMV. Which mode requires the patient to spontaneously breathing, have adequate lung function to maintain normal partial pressure of carbon dioxide, and not at risk for hypoventilation? The CPAPs. What does pressure support do? It just supports, augments spontaneous tidal volume, decreases spontaneous respiratory rate, and reduces patient's work of breathing. And how does pressure support decreases patient's spontaneous breathing rate? We have an increased volume, decreasing the need for high respiratory rate in order to achieve the required minute ventilation. Also, it decreases the dead space ventilation. What is desired respiratory rate during mechanical ventilation? Respiratory rate, it should be less than 25. Remember, more than 30 is an indication for mechanical ventilation. What is the tidal volume dependent on upon the pressure support mode? Dependent on the set inspiratory pressure, lung compliance, and airway resistance. What makes flow variable in pressure support? It's dependent upon the flow needed to maintain the plateau pressure. CPAP with pressure support is essentially BPAP. Is PEEP a standalone mode of ventilation? No, it's not. Actually, what are some of the positive effects of PEEP? PEEP normally just helps recruit alveoli and increases the FRI and the alveoli surface area and oxygenation. Complications of PEEP include cardiac compromise, increased intrathoracic pressure, decreased venous return, and decreased cardiac output and decreased BP. But an indication of PEEP post expiratory end pressure is the refractory hypoxemia. Is an inverse ratio ventilation, that is IRV, a volume controlled or pressure controlled? IRV is a pressure controlled mode. During mechanical ventilation, a long inspiration and a short expiration causes what? Long inspiration, short expiration. It causes air trapping and auto PEEP and prevents alveolar collapse. What is auto PEEP? This is just air trapping that occurs when there is an incomplete expiration. What are some complications of inverse ratio ventilation? Inverse ratio ventilation can cause barotrauma. It requires paralysis, sedation, and cardiovascular compromise. When is mandatory minute ventilation activated? Mandatory minute ventilation is activated when the patient's spontaneous breathing is less than the minimal set minute ventilation. When this occurs, the ventilator increases ventilation. Advantages of mandatory minute ventilation include promoting spontaneous breathing, requiring minimal support, protecting against hypoventilation, respiratory acidosis, permitting weaning, and while compensating for apnea. What are some indications for pressure control? It's indicated for patients with low lung compliance, high PIP during volume control ventilation, and in patients with acute respiratory distress syndrome. What are some of the advantages of pressure controlled ventilation? Of course, pressure controlled ventilation, the PIP is lower while maintaining adequate oxygenation and ventilation. There is also a lower risk of barotraumas with these pressure controlled ventilators. What mode of mechanical ventilation can provide a precise inspiratory to expiration ratio? The CMV, controlled mechanical ventilation, will provide a precise IE. API is inappropriate for what type of ventilator, for what type of a patient. This one should not be used in patients with inadequate spontaneous respiratory rate. So when does APRV resemble IRV? APRV resembles IRV when the expiratory pressure releases time is less than the spontaneous effort. And why is APRV a beneficial alternative to IRV? Because it does not require paralytic medication. And what is HFOV? This is a mode of ventilation that stands for high frequency oscillatory ventilation. High frequency oscillatory ventilation reduces the risk of lung destruction by keeping alveoli open at a constant pressure. It oscillates very rapidly and provides a high respiratory rate at very small tidal volumes. We have what we call as amplitude in high frequency oscillatory ventilation, and it refers to the change in stroke volume and the force delivered by the piston. Adjusting the amplitude setting helps control the patient's ventilation. What are the trigger variables for VC and CIMV? Of course, the trigger variables remain time, volume, and pressure. And what is the limit variable for VC? That's the volume is the limit. How does the trigger in assist ventilation work? Of course, the trigger can be time triggered or initiated by the patient. And what is the preferred ventilator mode for patients with respiratory distress? Of course, the assist control. Which mode can be used in acute respiratory distress syndrome, paralyzed or sedated? We'll still use the assist control until the patient is somehow stable to shift to the CMV. So we have several ventilator settings. We could look at the VT, the tidal volume, the frequency of respiratory rates, that is the FRR, fraction of inspired oxygen, FiO2, inspiratory versus expiratory ratio, IE, positive end expiratory pressure, PEEP, continuous positive airway pressure, CPAP, and the pressure support, the PS. So the tidal volume is normally abbreviated as VT, and this is simply the volume of air said to be delivered with each breath. In normal circumstances, normally 500 to 800 mils of air. Tidal volume is the tidal wave of air that we have to be aware of. FRR is simply refers to the frequency of respiratory cycles, and it refers to the number of breaths per minute, and normally 12 to 20 respiratory rate is the typical setting. FiO is the oxygen concentration of the air that is being delivered to the patient. Normally it's between 35 to 100%. You have to use the lowest possible fraction of oxygen to meet the patient oxygenation needs. IE is the duration of inspiration to expiration. The ratio is typically 1 to 2 or 1 to 1.5. PEEP is the positive end of expiratory pressure, and it normally pushes to keep the alveoli open. This pressure is applied at the end of expiration to distend the alveoli and prevent collapse. This keeps alveoli open with positive pressure at the end of respiration. Caution, you have to know that excess of PEEP can lead to conditions like barotrauma, which can eventually lead to a popped lung like pneumothorax. So which complication is associated with excessively high levels of PEEP? This is a common question, and the answer should always be the barotrauma or the pneumothorax. CPAP is a setting prompts the ventilator to deliver positive pressure to the airway throughout the respiratory cycle. It works only on patients who can breathe spontaneously. PS refers to pressure support, and this is the pressure that pushes air in. It pushes air to help with spontaneous breathing. Then we come to the monitoring of a vent. We have majorly three parameters. We could use the minute ventilation or minute volume, peak, that's the PIP, and the plateau pressure. So the minute ventilation or the minute volume refers to the ventilation every minute. So this amount of air delivered per minute. The vent measurement results from the multiplication of the respiratory and the vital volume, right? And the vital volume. Minute ventilation is equivalent to the total volume per minute entering and exiting the lungs. PIP, this is the pressure at the end of active inspiration necessary to overcome airway resistance and lung compliance. Airway resistance can increase the work of breathing, so PIP reflects both airway tone and lung stiffness increased by bronchospasm and or the atelectasis. Plateau pressure is pressure applied to hold open small airways and alveoli before expiration, and this indicates the lung compliance. Remember, we have several nursing diagnoses of patients suffering or patient on a vent. We could have ineffective airway clearance, or we could have impaired gas exchange. Patient could suffering from risk of infection, impaired verbal communication, risk for imbalanced nutrition, and anxiety related to dependence on the ME. Best practice for nursing care of a patient who is on mechanical or ventilation include manual resuscitation bag as well as re-intubation equipment, which includes 2 different tube sizes should be available beside the bed. You need to regularly assess patients' levels of consciousness and the vital signs, their breath sound as well as pulse oximetry and their ABGs. You suction their oral and the tracheal secretions as needed. Reposition their ET every 24 hours or more frequently to prevent skin breakdown. You have to remember that if the tube is just left to rest there against the mucosa, it can damage and cause pressure injuries, and that will be hospital acquired pressure injuries. Provide patient with frequent oral care and monitor for complications such as ventilator associated pneumonia. After extubation, you encourage the patient to take deep breaths, cough, and use incentive spirometry. Okay, thank you so much, guys. Kindly go through the content and share also with your classmates, and let's share your feedback so that we can be able to know. Thank you so much.